Our final speaker comes to us from Health and Human Services. John is the Deputy CIO for HHS. His profile is in your book, but I think it's important to point out a few things. He has over 27 years in HHS, having worked in CMS, CDC, and the Social Security Administration. David Jenkins highly recommended John join us for this talk and be able to provide us this talk. I spent about a half hour with John earlier this morning, and going over, sharing with him what we've been talking about the past few days, the context of what we do. I, like David Jenkins, conclude that John gets it. He understands what we're doing, why we're doing it, why we're here, what interoperability is all about. So without further words, please join me in welcoming John Teeter.
Okay, so if I say anything untoward or I have a message that is inconsistent with your way of thinking, it's David Jenkins' fault. So what I'd like to do is I'd like to just start with a couple of observations. I've been listening to you all, and I think that there's a couple of really important points. And one is that IT is just a tool, and so you can automate a bad process to perfection, and it's still a bad process. And so, those are the reasons that you have to talk to the folks that are actually in the trenches. You guys are in the trenches. The people that are delivering services. I have to share a story. Rick and I were at a nationwide health information network conference many years ago when they were first starting to talk about a nationwide health information network. And I was up there and I was very passionately promoting a nationwide health information network, and it was just the greatest thing. Information sharing was going to prevail, and the problems of healthcare were going to be solved. Rick came up after me and he said, and I use this analogy. I said, so if you're building something, typically what you do, the first thing you do around your house, you go to Home Depot or Lowe's and ask these people, well, what's the best way to do this? And so the idea here is these are available. It's a nationwide chain, et cetera, et cetera. Rick gets up after me and he says, well, John, while I think that has value, I would go to the local hardware store, the guy that lives in your neighborhood and knows your community the best, to find out how best to solve this problem. And I thought to myself, I said, well, what a revelation. I mean, you talked about epiphanies that everybody else had. And I said, well, that's it. That's where the rubber meets the road. And so the value of the folks that are actually delivering services and providing input into all of this is exponentially greater than if you take a top-down approach to this. And now there's value in the top-down approach in coordinating across all of this, but the people that really suffer through the day-to-day operational complexities are the ones that are at the local levels. And so I've never forgotten that. So thank you, Rick. I appreciate that. And I think that that's really what we're talking about here today, is interoperability across all of those perspectives. And so I heard another point that was coming through, and that is, well, how do we measure this? Are we measuring the right things? And I think that, the reality is you should know what it is that you're measuring or what you're trying to accomplish before you ever get started. Because otherwise, if you don't know what you're trying to accomplish, then how are you going to develop a plan to do that? It's like the old axiom, if you don't know what direction you're going in, any direction will do, if you don't know where you're going to end up. And so I think those are some of the key pieces that I'd like to offer, and I think that the other thing is it's all about people. We don't do these things to to deliver IT systems. We do these things to improve the human condition, to deliver healthcare services better. And so these are some of the things that we are trying to do. Kathleen Sebelius is our secretary at HHS, so we're trying to transform healthcare. We're trying to implement the Recovery Act, promote childhood health and development, and all these things. I don't need to read these to you all. You all know these things. But these are the things. You start off with a direction, and then you start to figure out how to achieve that direction. And so, you know, one of our priorities at HHS is interoperability and information sharing. It's key. I have to tell you a little bit of a personal story, and that is I just recently changed my healthcare provider. You know, so I'm now part of the Johns Hopkins community of healthcare providers, and so I went in, and it just happened that they had electronic health records that had been installed, and so the doctor, wonderful lady, looked at me and she said, "Are you experiencing any muscular problems?" And I looked at her and I said, "Well, no, this is just a routine physical. I don't have any problems." And she said, "Well, I note here that you had childhood polio, and there is an adult syndrome that is being tracked right now that causes muscular problems in adulthood for those that had childhood polio." And I said, "Well, I never knew about it." and so she said, "Well, we're going to watch that." And I thought, well, I was like 3 or 4 years old when this happened. How did she know that? And apparently she had done her due diligence and collected the longitudinal history for me, which I thought was exceptional, but if she had not had that longitudinal history, then she would have never known to pay attention to this. So information sharing is key, interoperability across multiple areas, and I think that HHS should lead the way in promoting this, working with you all to do this in an effective way. But the question really is, how do we manage a large, complex business and all the interactions that result from that complexity? And ultimately, the impact is delivering more effective services. So what we're trying to do is we're trying to chunk this up, and we've been trying to do this based on a domain approach. And you all have been talking about the National Information Exchange model, and so they take a domain approach. And so what we're saying is that there are certain areas of function that we should look at. So health, human services, research, maybe population health is another specialized area that needs to be addressed separately. I'd be interested in hearing your perspectives on that, because I've heard it both ways. Is it a separate endeavor? Does it have a separate community, and should it be treated separately? Or is it simply an extension of the health care or the health domain? And so I'd be interested, as we engage in our discussions, to hear what you have to say on that. And then there's this underlying infrastructure that across all of these domains that shore up in this graphic the HHS mission. And that infrastructure, I think, is very key, because at the federal level, what we can do within HHS is we can say, all right, we're going to take a common approach to delivering this infrastructure. Now, one thing that I also heard in talking with you all and talking with others is, how do we facilitate that in the grant world? So how do we push money out to support these various programs that you all administer for the citizens, and how do we build that common infrastructure and still stay in line with the letter of the law and the regulatory constraints that we have there? And so I will tell you that I'm having those conversations with OMB. And I think that OMB is interested in some change in that area. I think that we're going to have to walk across the aisle within OMB, though, and see what the effect of that's going to be on the budget side of the House. So the management side of the House gets this, but the budget side of the House, they have to deal with the appropriations committees and things of that nature, and the appropriations committees look at things a little bit differently. So we're going to talk about that a little bit. So how are we approaching this? We've established the health domain. And I should say, for those of you that don't know, just recently HHS became a member of the steering committee for the National Information Exchange model. I sit on that steering committee, and so we've agreed to stand up the health domain, and we've agreed to stand up the human services domain. David Jenkins is very involved in that, and as you probably well know. And so this is an opportunity for us to chunk these things up, and we'll talk a little bit later on about how this model, this National Information Exchange model, might evolve. And there's a couple of things here dealing with using the semantic web and using standard APIs for accessing the semantic web constructs a little bit more ubiquitously, across the domains. But we'll reserve that. So this is really what we're talking about here as we're looking at things within HHS. There's all kinds of drivers, or as I try and simplify things, these are all just additional requirements that we have to satisfy within a domain. And I will tell you, I'm constantly frustrated by the federal government's reaction to new requirements. The first thing they say is, oh, God, we got to stand up a governance committee. We got to stand up this work group, and they're going to perpetuate, forever. And so now we've got silos of interactions to satisfy requirements that by necessity are related. And so what we really need is we need to have a consistent governance approach where the requirements come in, they get addressed, and they get reflected within the entirety, and that's the only way that we get to interoperability and information sharing and shared services and things of that nature. So this is kind of what we've started to look at things in this kind of a perspective. So there's and you might see up at the top here, I've also put in an interaction with the states. There's the START program that David and I have been working with, and so we've got all these people that are coming to the table saying, look, we've got common requirements. Let's take a look at how to address them in a common way. So we bring those requirements in, and at the bottom you can see that you've got multiple stakeholders that use the results of all of these health IT projects that, in some cases can help satisfy those requirements. And so specific to the Affordable Care Act, this is kind of the construct that we've set up so that we have, and I forget who it was that said that there is like an executive board of directors, it might have been Linda that said that, where you have a high-level group that actually makes decisions on the direction and the vision. And so we're trying to mirror that type of good thought so that we have a health vision and strategy group that takes a look at new requirements as they come into the department, whether it's by law or executive order or OMB directive, whatever. And then we determine, okay, is there an opportunity for the IT steering committee to provide value in helping to satisfy those requirements? There won't always be an opportunity. I think the gentleman who spoke about, he's from the IT shop, said, IT can't always be the solution. Sometimes it's a business process change that it has the most effect. So we need to be open to that. And then we're starting to look across using this health reform IT PMO, looking across all of these requirements, and this is a group that actually looks at the Affordable Care Act and the Recovery and Reinvestment Act, and talks about the requirements that are being funneled in from there, and the ongoing responsibilities of the Office of the National Coordinator for Health IT in advancing electronic health records, because all this stuff has to fit together, and in the past they've been kind of siloed. So I think that this is a different approach, and hopefully what we can do is we can have at the lower levels, we can have integrated project teams so for instance, our Office of the National Coordinator might have one, and then our Centers for Medicare and Medicaid Services might have one. Our Administration on Aging might have one, or our Healthcare Finance Administration, Health Research and Services Administration, Healthcare Finance Administration. For those of you that might not know, I know this because I'm old. That's what CMS used to be called. And actually, you all probably remember way back when SSA was part of HHS. I was there. You know, I'm like one of those dinosaurs. So anyway, so this is a change in the way we do business, and I might suggest that this is also an opportunity for us to bring the integrated project team concept into our interactions with state and local communities as well. So we have federal, state, local, tribal, everybody, working towards the same set of goals. So this is just an example of the types of things that we're doing in the health domain and with respect to the mission. So we're starting off trying to do these things at a high level within this broader perspective of the health domain. So we're trying to chunk it up and say, these are the things that we need to do. So now we've got a basis for saying, okay, when we have a new program that comes forward, or a new IT initiative that comes forward in support of those programs, which one of these is it supporting? And how is it supporting that? And so now we're getting back to the discussion we had before about measurement and performance measurement. Are these things actually providing the value that they're intended to provide? Are they making a difference at the point of delivery of health care or human services delivery, whichever the subject domain might be? So we're in the particular area of electronic health information exchange. This is what we're striving for, and I don't think this is a mystery to anybody. I told you about my own personal experience where there's more information, you can have better care, better perspectives on those types of things, elimination of potentially medical errors, et cetera. And so these are all the things that we're trying to accomplish, and I won't read these to you. The Nationwide Health Information Network, we need something like this. I'm not sure that we have what we need right now, and I'm not sure that the total direction is absolutely defined right now. I think that the specificity for how to implement a nationwide health information network is still under evolution, and I'm sure that you all are experiencing that as well. So we need to come together to promote the interoperability, as you see down here on the third bullet from the bottom. Promote interoperability among regional, state, and local health exchanges, whatever form that might take. There's going to be federal instances, there's going to be state instances, there's going to be local instances, but the real thing is identifying the opportunity for interoperability and information exchange, and we'll talk a little bit more about the services that are associated with that as we move forward. So the National Information Exchange model is a way to do some of this. The National Information Exchange model, as you all probably well know, starts off with a particular business context, and says, within this business context, this is a standard information exchange that we'd like to pursue. Now, where I think that it can evolve, and it does produce the result of information sharing and focus on those information exchanges. But where I think it needs to evolve is into the area of services and shared services in particular. Not to be too political, but but Rahm Emanuel said, "Never waste a good crisis." Well, we've got a budget crisis. And so what we can do is, as a community, as a collective, we should probably come together, just as we've done with the National Information Exchange model, and say, okay, if within this particular business context we're going to exchange this information, maybe what we ought to do is we ought to develop a common service that we can all then share. So instead of, of each state, territory, and large metropolitan area developing this themselves, which would equate to probably 60-some times, maybe what we ought to do is come together as a community and say, within this business context, if we're going to exchange this information, we're going to do it in this way, and here's a service that you can use to do that. And it costs you nothing, because it's just part of our library of services, of common services. So now, instead of paying for this 60-some times, we've done it once, and everybody has that basis. So this is kind of a revolution of thought, I guess. I have a lot of people look at me funny when I say these types of things, but I absolutely believe that this is an opportunity, and so we should pursue that opportunity. And you all are completely on board with this, I know. So that you take a look at that value proposition and you say, these are the things on the left-hand side that NEAM can do for us. And then the relevance to HHS is on the other side. Now, I might add, you talk about Medicare fraud and detection, child support enforcement, things like that. I will tell you that there have been people that have come up to me and they say, I can help with Medicare fraud. I can solve this problem. And so I said, well, indeed, tell me more. Because, I mean, we're looking at about $20 billion, I believe, within Medicare that we estimate is wasted. And billion with a B. I mean, that's a lot of money. And so what I typically do is I challenge them and say, how are you going to do this? And I said, and they said, well, we've got this fantastic tool. It does all these analytics and things like that. I said, so if you are absolutely sure that it's going to provide this kind of value, then why don't you build the system using your tool, and you accept as your compensation a percentage of what you save the government. And I said, hey, look, you're looking at $20 billion. You start to even take 1% of that. That's real money. And so they look at me and they say, well, I've got to go back to the corporate office and get approval for that, and which is probably right. But the real key there is not the technology, it's the availability of the information. Because what they say is they need to have access to the information prior to payment, because we operate now in our zeal to make payments in a timely fashion. We operate in a pay and chase type mode. And so now what they're saying is we need to have access to the information up front, and then we can prevent some of these payments from occurring to start with. And so I think that's just just one example of how this can all be relevant to HHS as you take a structured approach to providing and collecting information across multiple programs. And so, and obviously the programs are administered across the country. They're not administered in Washington. I mean the programs are operated and supported across the country. So that's just one example, and you can read through these others as well. Now let's talk about the evolution of NEAM in the areas of both data and services. So my contention is, and this is something that I've been talking with the NEAM folks about now that I'm fully empowered to execute as a voting member of the Executive Steering Committee and in good standing in that regard. So we take a look at the data and we say, okay, what's the next evolution? What's the next big thing that really will cause this issue to help to improve exponentially? Well, again, it's all about the data. But what NEAM seeks to do right now is it seeks to, within a particular business context, define the data that is to be exchanged. And this is absolutely a good thing. Don't get me wrong when I say this. This is absolutely the right way to go, and particularly in those areas of transactional exchange where a lot of structure is important. But if you, how many people use Google? Yeah, I do too. Yeah, how many people use Bing? You know, how many? Alta Vista, you know, whatever. Going way back now. So anyway, that is, you don't have to have a structure to access data and information when you use those. You don't have to understand that structure. And so the semantic web, which is really how they produce all of that tremendous result through their search engines, you have an ontology that has data definitions and the relationships amongst those objects of data that are now able to be consumed by some of these social media tools, and many of them are free. So you consume this hierarchy of data and the relationships associated with that and the data definitions. And then you have metadata, and obviously the search engines work on the metadata that is associated with instances of published data. Then you have metadata that says this object within this ontology has this number of instances. So when you go out to do a search engine, to use a search engine, it just knows where all the instances of that data might reside. And it brings back the information based on certain relevancy, obviously. The next evolution of NEAM, I believe, could take advantage of that, and instead of having each and every information exchange defined at a finite level and very detailed level, we could allow people to publish data that they already have developed using their interpretation of the relationship to this hierarchy of data definitions. And now what you've got is you have the ability to do the second thing, which is to do very common services. So for those of you that are very technically inclined, you've got HTTP, this Common Internet Protocol. And so you can do an HTTP GET to go out and pull this information back using the metadata that has been published for that. And so now you've got all this data that's available to you, and maybe it doesn't have the precision that is required for like analytical research and or financial transactions. But now you've got this data that's available to you in kind of a new way, and you get an exponentially larger amount of data that you can start to do analytics on. And I will tell you that we believe in this so strongly that at HHS, everybody familiar with data.gov? Okay, so data.gov is a federal implementation of data access points. We believe in this so strongly that we have taken the responsibility to develop a healthdata.gov. Again, the domain approach, but it's going to be a collection across the federal space of health data, and so people that are engaged in this particular domain can go in and access this. And we're going to have a version of that is semantically expressed. So, and then you can build those very simple services using the internet protocols that the search engines use to access the data. So this is something to come. I also have a gentleman that works for me. His name is George Thomas, who is the co-chair of a W3C work group to advance the use of the semantic web. And so we're making investments in this because we think this is a potential for evolutionary change. We've talked about this, but the big thing here is I think this is consistent with the Open Government Directive that allows for more information to be shared and more people to use that data than ever before. And so you have the transparency of the data. You have the opportunity for people to participate, and then you can collaborate across communities based on the results of your participation in the use of that data. And so, but I think that this is a next evolution here. And I think, honestly, you're going to need both. You're going to need both the structured approach that NEEM offers today, and then you're going to need this approach to actually make more data available more rapidly as we move forward. And the result will be that as data is published semantically, it will use the constructs and the definitions of NEEM, information exchanges, and now you won't have, you will have the semantic web will now be published in a more structured way. And so, it's an evolution. That's why I call it that. So this is kind of what we're talking about here. The good thing about standards is there's so many of them. and so NEEM operates as a funnel, if you will. So within a particular business context, you can have all of these standards flow in, and you end up with a NEEM conformant IEPD within a particular domain. And this is kind of the model. The good thing and the most valid point here is NEEM does not prevent you from using voluntary industry standards. It actually embraces the ability for you to do that, and that's one of the biggest objections I have from folks who don't really understand NEEM is that they say, well, we use HL7, and I say, okay, go ahead, you can do that within NEEM. NEEM will allow you to do that. You just have to reach an agreement that some aspect of HL7 definitions and clarity are part of the information exchange package. But you all do that. You all come to the table and agree on that. So as we talk about the services, this is something that is part of the Affordable Care Act, the Community Living Assistance Service and Support class program, basically long-term care insurance. And so this is kind of a very simple model that shows how NEEM information exchanges can be developed. So you have standardized data exchanges, and then you have services, and I apologize for the misspelling here. You have services that are used to support all of this class program. And so those services, as we extend out, these services create a bridge between the things that we're doing for health and human services missions accomplishment, but it blends it now with other domains, the financial domain that Treasury may be involved in, or SSA may be involved in, and education for verification of student status or things like that. Basically, this is an acknowledgement of what you heard from New York City, that they recognize that all of these things fit together at some level. And so this is an acknowledgement that this has occurred. And so this is really what we're talking about is you can develop these information exchange packages that operate on the edge of various domains, and I think that's a key point, key takeaway. Now, if you look at another program, the Health Insurance Exchange Program of the Affordable Care Act, you can see that, if you use this model, it looks very similar. And if you look at it closely, you can see that a lot of the services are actually the same. And so this is the opportunity that we talked about before of extending the NEAM model into this service area so that we can actually produce services. And I have to tell you that I absolutely believe that all of the good work that has gone on previously will, if we just bring that good work to the table and we say, here's what we're doing now, here's what we've already agreed to do within certain communities, we can actually make that very visible and very quickly have a library of information exchange packages and services that are already being used in a practical sense so that we can now publish all of that information for those that maybe don't have those services or don't have the clarity of the information exchange packages. They can reuse that stuff, and I might add that the latest statistics for mature organizations or organizations that are mature in the use of NEAM estimate that you could probably save as much as 60% of the cost, because now you're not reinventing the wheel. You're actually consuming things that have already been done. So in these tight budget times, if we operate within a community of practice that facilitates interoperability and data sharing, then we can do great things. And so this is just an example of that. So we need to absolutely improve the security architecture. We need to document the current architecture. We need to catalog the current services that we're all already using. Let's leverage the good work that's already been done. And then we can standardize, consolidate, and automate to take advantage of things like cloud computing. I mean, one of the things in the Affordable Care Act that we're contemplating is standing up a cloud so that we can collaborate with the states in developing these common services in the cloud. So one of the advantages of a cloud is you can stand up a development environment pretty quickly. And so you stand this up, and then you got to have a collaboration space where the federal government and the state governments, the local governments, et cetera, can come in and develop services, but now they're only doing it one time, but they're sharing all of the requirements. And so the local requirements and actually the intelligence, the operational intelligence that Rick and I talked about before are being put into the thought processes of the federal evolution as well. And so there's an opportunity here for this collaboration to produce a lot of shared requirements.
John, and, I want to leave some time for questions.
Oh, sure. Okay, we can go through there. That's just statistics. That's another example. We talked about risk management. The one thing that I want to mention here is we've just recently had this 25-point IT reform plan that OMB has published. One of the things that it calls for in that plan, take care, thank you. One of the things that it calls for within that plan is innovative approaches to funding, and so that would include opportunities to differentiate the way we do our grants work. So that's a big deal, and we are talking with them about that. Structured approach to looking across domains, common themes. And now we're at questions. As you all can tell, I'm pretty easygoing. I'm fairly informal, and so whatever you guys want to make this is what we will. Yes, ma'am.
Our first question is, could we have a copy of your slides?
Yes.
No, that was the question.
We're way ahead of you.
So, John, thank you very much for that. It's clearly a tremendous amount of effort and energy going into the health world, electronic health records, exchanges, NEEM, all that kind of stuff. The question that I think I have and a lot of people have here is, so, there's a HS, and the second HS is part of a lot of the people's focus here in terms of how does human services get into that. I noticed on the very first slide, there wasn't actually a specific point on human services in terms of the the Secretary's priorities.
Yeah.
And we've struggled now for the last couple of days to make sure, given the momentum, given the investments, given the architectures going on, how do we make sure that human services is attaching ourselves to that in a meaningful way and taking advantage of the energy that's going forward now?
Yeah, I intentionally didn't put a whole lot of content in here about human services because I knew that David was going to be presenting, on human services. But I think that if you look at the first slide, you can see where human services fits into a lot of that. So elimination of improper payments, fraud, waste, and abuse control, information sharing, and shared services. All of those things, David and I have long since recognized that there's a correlation, and I will tell you this is kind of the world according to John here, and not to be construed as official HHS position by any means, but I absolutely believe that when we start to collect information about an individual across their life cycle, this longitudinal record of human events, I absolutely believe that we will find that there is a direct correlation between the human condition, particularly in developmental years of an individual, that have an impact on the health care requirements that they may potentially have in the future. And so having that kind of an information sharing across those domains, I think, is going to be extremely important. And because then you can start to target your programs. So, for instance, one of the things that we did within the context of open government, and it is referenced in here in the slides, is we developed a perspective on community health indicators. And so we published all this information. It was I think it was 1,100 or 1,400 health indicators based on community or geographical perspectives. That did a couple of things. First off, it made the data available to people. And so one of the things that someone did right off the bat was they said, okay, obviously, who's the healthiest and who's the worst? Okay, so they did that. And so now all of a sudden the person who's on the bottom of this list geographically says, hey, I don't want to be at the bottom. And so now they started to look at the areas where they were considered deficient from a health indicator perspective, and then they looked up the chain to those that were doing this well in other communities, and they had a conversation. It wasn't long before the one that was on the bottom was no longer on the bottom. So just sharing the information had an effect. I absolutely believe that when we start to take a look at that same type of an effect, sharing data across the human services and the health domains, that we're going to be able to very quickly start to get to some root causes in some cases of healthcare needs that we can trace back to maybe deficiencies in human condition, maybe nutritional deficiencies at some point in early development, or maybe there's a correlation between access to education or how effective or not effective but good housing or something like that, something that affects the human condition early on that might have a correlation to healthcare costs later on. And so this is just, and I'm not saying that this is science. Believe me, I'm not saying this is science. That's why I articulated this as the world according to John. But as soon as we have the information, we can start to analyze it. And we can start to see if there are patterns that we can identify and opportunities for us to identify where our grant programs should be targeted or where our human services programs should be targeted. Another aspect of publishing this data on health indicators allowed people to take already published and available grant information, and they were able to say, and I think they did it in Texas, if I'm not mistaken. They said, okay, this grant is intended to produce this result. Is it doing it in Texas? And so what they found out was that there was a higher correlation of grant dollars in areas that had a reduction in the human condition, but there was a lower correlation of grant dollars in those that had a higher instance of adverse human condition. Okay, so what do you do with that information? Does that mean that we're not allocating the grant dollars appropriately? Or does it mean that where you're allocating the grant dollars, it's having the desired effect? So it's either a positive or a negative, but once you can do that analytic work with the information, now you can start to drill down into the root cause, and that was a long-winded answer.
Let me give another question.
Yes.
This is a question and I guess a request. I'm from Illinois, the Chief Information Officer for our Medicaid and Child Support Organization, but we have to do a lot of new things, and we want to be NEEM compatible, but we want to use vendors. We built our own MMIS. We've done all this stuff 30 years ago. We don't want to do it again. The problem that I think we have is while we like the standards, they're not really mandatory. And what that means is we have a lot of vendors out there that have got a lot of money, that they put into a lot of code. And right now they're kind of risk averse. We know that. If the federal government were to say, by the way, these are standards we're going to enforce, everyone would be writing code to that. It would really make it easier for us. When the standards are suggested, people like them, it doesn't tend to encourage the people we want to build the products that we want to use, to build the products we want to use. And I think that's been a problem that could be addressed kind of, I don't know how easy it is politically, but it would be nice, I think, from our point of view, to see much tighter standards, because I don't think at the level we're talking about, it's not going to affect policy. It'll enable policy if we could see that happen.
Yeah, I think that's right. I think a long-standing practice in industry has been to create competitive differentiation wherever you can, and some of that is in maintaining multiple proprietary standards, whether that's on the data side or whether that's on the technology side. Both of which affect interoperability and the information sharing opportunities. So what we're doing is, I'm talking to OMB about this, and I've actually said, I know you guys you shy away for political purposes. You shy away from declaring winners and losers, let's say, because that's how it's politically perceived, is the government is picking winners and losers here. But I told them that to achieve interoperability across multiple levels of government and out into the private sector, you're going to have to do some of that. And the real opportunity here is to adopt voluntary industry standards that are maintained by the standards development organizations wherever there's a value in doing that. So now it's not a federal standard that we're promoting. It's something that industry has determined has value already. And so, but at the same time, you're going to have to decide which pieces of that standard are you going to adopt as a required method of fostering interoperability. So you're absolutely right. We're having those discussions. I'm not sure I have a good answer as to when we'll get beyond this, but you're right. As soon as we do this, then the vendor community will start to implement the standards as required, and now their products that they're offering will the mode of differentiation will be based on innovation and enhanced business value rather than on proprietary standards. And I think that's what you're saying. And so we're having those conversations, but I don't have a time when they're going to come to that declaration. But I will tell you, on the electronic health record side, they're starting to get there because they're starting to promote certain standards within the meaningful use context. And I think it's just going to get tighter and tighter as we move forward, because it has to. Yeah.
I may have
Who's
a
next?
yes or no question for you, and it relates to
Yes.
Daniel's question and how you started your presentation, which was around your doctor today knowing about your medical history
Yeah,
when you were
yeah.
4. So there was one slide that referenced education in a very refined or sort of narrow context, and I wonder, for so many of our children, for generations, school nurses are their primary care provider.
Yeah.
And that is where their vision screenings have been done and their hearing screenings, and where they've gotten a lot of medical treatment. And if there is not robust data sharing with the departments of education in the states and across the country, all of that data will be lost. That's in their CUME files.
Yeah.
So is there a plan to do that level of sharing with education across the other domains?
Yeah, we're actually talking with the folks in education now, and we've got OMB involved in this as well, because if that information is not included as part of the health history, then there's a gap. And I forget who the gentleman was that talked about. Well, if people exclude certain pieces of data from their electronic health record, then is it of value? And so it certainly does diminish the value, as you pointed out. So we are actively having those conversations, and hopefully we'll get that resolved.
John, let me ask something. Throughout the 2.5 days, we've had a lot of discussion and a lot of revelations about all the funding from healthcare, the HIEs, the HITs, the 90/10, so on and so forth. One of the things that's been common throughout the couple days has been the fear that we're incenting states, backing them into a corner in some cases, to go create separate silos again, a separate eligibility system instead of a common eligibility, and we're only going to perpetrate this lack of interoperability and ineffectiveness and inefficiency. Any thoughts, or how you and the CIO organization are trying to deal with that dilemma, I think, in some respects?
Yeah, I think this is why I'm suggesting that we evolve from just the business and the data context of NEAM to kind of having common services that we all share. And once we start doing that, then we can look across the domain. So we can say, okay, well, here's a service that can maybe do certain aspect of eligibility verification on both the human services side and on the health side. And so now we can all come together to do that. OMB gets that. Like I said, we're having those conversations. It's the budget side of the house that we have to kind of corral a little bit, so that they don't. Well, I was going to say unintentionally, but sometimes it seems intentional that they are creating these stovepipes by their budget allocations. They're saying this money is used for this purpose, and so it's unclear to me whether that is actually an intended consequence or unintended. I think.
All right, one more. Go ahead, Mary.
Just to follow up on Jerry's kind of comment, when you create the stovepipe in the budget at the federal level, it follows right down to the service provision level in localities, just to recognize that. And you said that if you buy a service, that it's the same. Does that mean that there's a consideration that it can be funded using any one of those sources and not cost allocated across?
Yeah, we're actually having those conversations about how we can allow, not even allow, but actually require common infrastructure to be reused across programs.
So
And
Medicaid buys 90/10 service, like, using 90/10 money, does that mean it can be used across, across in another domain if it's applicable?
That's the discussion we're having. Now, is that a remedy available today? No. But that is the discussion we're having. Yeah. And the gentleman back here was being very patient, I thought.
If you're going to wrap up, I can do it.
One more.
I was intrigued by what you were saying when you're talking about Medicare fraud and the conversation you've had with vendors in terms of, you say you can save a lot of money. Do you want to bear some of the risk in getting to that when you prove that you can save it? The more general conversation for some of us who live over in the child welfare world, and where there have been a couple of waves of privatization, goes, we can save a lot by privatizing the system, and we're going to have all these benefits later down the line. My question is, are there any examples at all from the information side of vendors bearing that risk and reaping the benefits?
Not in the sense that there is a persistent agreement to do so with any of our programs. I will tell you that some of them have come in and they have done pilots to demonstrate the value of what they're saying and the efficacy of their approach, and it seems very promising. And so, but what they heretofore, what they've wanted to do is they've wanted the government to pay for all of this up front and pay a flat fee, and I'm challenging them to do otherwise and share the risk, obviously.
Good for you. It would seem to me that if the federal government tried pilots of issuing that invitation/challenge and got some vendors to step up, or documented that no vendors will step up to that challenge, we'd have advanced the conversation between a very hard-strapped set of governments and vendors who will claim extraordinary benefits but not want to share the risks.
Right. I think that's right. And so one thing that I've done is we at HHS we have a director of innovation, and so some of these proposals that articulate the potential value of cost savings in this fraud area, we've sent some of their proposals to that innovation group to maybe implement as a cost sharing implementation. We haven't gotten anybody that's actually worked through their corporate channels to do that effectively yet. But we're working on it. We're working on it. So hopefully we'll have something good to say.